Welcome back to the Brown Surgery Podcast. Today we're going to continue our Quick Shot podcast series on the basics of mechanical ventilation. Joining me today is Dr. Tareq Kheirbek. Tareq is an associate professor of surgery here at Brown and one of our trauma critical care faculty. All right, so I'd like to welcome Dr. Tareq Kheirbek to the podcast today.
Thanks for having me.
Jumping right into it, Dr. Kheirbek, why do we put patients on positive pressure ventilation?
You will see that patients are put on ventilation in the hospital in three settings, either in the emergency room, in the ICU, or in the operating room. And I like to think about it for indications of the ventilation being three categories. There's an airway protection, somebody with a traumatic brain injury, angioedema, anaphylaxis. There is a hyperventilatory respiratory failure, somebody who is not able to ventilate very well or cannot keep up with the metabolic demand. And for oxygenation problems, we saw a lot of this during COVID where patients got intubated for refractory hypoxemia. And if you think about these categories, then you have to remember that the ultimate goal of putting somebody on a ventilator is to extubate them, get him off the ventilator. And if you keep in mind the indication of why a patient got on a ventilator, then you can do your work and management to address the indication for intubation and ventilator support so you can eventually extubate the patient.
How do we set up vent settings? I think that's a question that especially novices or interns find themselves in the position where they get a patient from the operating room and they have no idea what the respiratory therapist is putting the patient on.
So commonly when you review ventilator settings, you will see us talk about four major parameters on a ventilator. There is FiO2 or the fraction of inhaled oxygen. There is the PEEP, positive inexpiratory pressure. Respiratory rate, the one that you set on a ventilator, which is different sometimes from the one that the patient breathed. And then there is a driving pressure or a tidal volume. I like to think of ventilator settings in two different parts. There is the oxygenation and the ventilation. So first thing I'm going to address oxygenation. If patient gets intubated, you want to start first with 100% oxygen and adequate PEEP to support the patient. Generally, we start between 5 to 8 of PEEP. Sometimes you'll have to start with a higher PEEP if the patient gets intubated for ARDS or acute hypoxic respiratory failure. And then you follow the patient's response to these settings and try to start weaning the FiO2 and the PEEP to a stable level that you can maintain the patient on.
Okay, so that's our oxygenation settings there. What about our ventilation settings?
So when we want to set up a ventilator with the ventilatory settings, we're now talking about respiratory rate and tidal volume. And depends on how we're setting the ventilator, we either have to set a driving pressure that will deliver the intended volume by setting a pressure in a pressure control mode, or we set the volume delivered in a volume control mode. Either way, the most important part of this is the relationship between volume and respiratory rate, which we call the minute ventilation, and that is the amount of volume the patient is exchanging over a minute. So a normal minute ventilation is about 5 to 7 liters a minute, and that is in a normal human being breathing normally, no distress. You would expect in somebody who is intubated for higher metabolic demand or process like septic shock or burn that they will require a higher minute ventilation to get rid of the CO2 that the body is producing. So septic shock, I would expect them to have a minute ventilation between 8, 10. In burns, probably around 12 to 14 if there's significant burn. So when I set the ventilator, I will then decide what is an appropriate tidal volume for a patient. We know from the ARTSNet trial that a lower tidal volume is safer than a higher tidal volume. In somebody who has acute respiratory distress syndrome or ARDS, you want that volume to be about 4 to 6 mLs a kilogram of ideal body weight. In somebody without lung injury or ARDS, we accept a volume between 6 to 8 mLs a kilogram. So usually 6 mLs a kilogram for ideal body weight is the number that I go to when I'm setting up the ventilator initially. So in somebody who is 70-inch tall man, their ideal body weight will be around 70 kilograms, 75 kilograms. So if I want to choose 6 mLs a kilogram, that will end up being a target tidal volume of 420, maybe 450, which will be a safe tidal volume. Now I said that my minute ventilation in a septic shock patient would be between 8 to 10. If we want to make the math easy, I'm shooting for a tidal volume of 450 mLs with a minute ventilation of 9. Then my respiratory rate that I want the patient to breathe at will be around 20. So my settings for ventilation will be setting either a tidal volume of 450, a rate of 20, a FiO2 of 100%, and a PEEP 5 to 8, depends on what I think the oxygenation level is initially. If I'm using a pressure control mode, then I have to use a driving pressure that will achieve the target volume based on the ideal body weight. And it's okay to start with a random number between 12 or 15, 16 of a driving pressure. And then watch your tidal volume and try to adjust the driving pressure to make sure you're not overventilating the patient and also not hypoventilating the patient.
Let's just say you intubated a patient over in the TICU. What can you do to get them up and running on the ventilator in a safe manner?
First rule when you're managing a ventilator or setting it up for it initially is to have a good relationship with your respiratory therapist. They know a lot about the ventilator, but it is also important that the provider, you as a resident or a fellow, to know enough about the ventilator so that you can manage and troubleshoot sudden changes in the patient's status. In Rhode Island Hospital, we most commonly use a pressure control ventilation. So I would use a pressure control ventilation with a PEEP of 5, FiO2 of 100%. And then as a start, I would do a pressure control between 12 to 16, monitoring the tidal volume and making sure it is within a safe range for the patient based on their gender and height. And I will match the respiratory rate to achieve a minute ventilation that I believe will match the patient's metabolic demand. And generally, that will be between 16 and 20 breaths a minute.
I know a question comes up. So how do you know that you've got the right setting selected? What should be their protocol?
After I have the initial settings of the ventilator chosen, I will monitor first the patient's comfort on the ventilator, make sure that I'm not using a high volume that the patient is not comfortable with or a high pressure that the patient is not comfortable with. After the patient settles on a ventilator, it is wise to get initial ABG, arterial blood gas, to monitor the acid-base status of the patient and the level of oxygen in the blood using PaO2 as well as the oxygen saturation. If I get an ABG and based on my analysis, I find that the patient is in respiratory acidosis because of hypoventilation, then I know that the ventilator settings are not matching the patient's demand to get rid of CO2, and I will have to drive the ventilation higher.
Yeah, so I'm glad you mentioned that because I think that's a common scenario that residents are going to see. Let's say they do get that ABG back and the pH is 7.24 and their PCO2 is 60. So they diagnose a respiratory acidosis and now they have to make an adjustment to the ventilator settings. How should they proceed?
In this case, I wanted to try to choose whether I need to go up on volume or tidal volume or I want to go up on the respiratory rate. Again, the goal is to improve the minute ventilation. So you have to choose one of the two or maybe both. So one, I will make sure that if I go up on a tidal volume, I'm not reaching level of ventilation that's going to result in over distension of the alveoli. Again, I want to keep my tidal volume less than 8 mLs a kilogram of ideal body weight. If my initial settings were based on 6 mLs a kilogram and I have a window to go up on the ventilation, then I would increase the tidal volume or increase the driving pressure that will achieve a higher tidal volume. If I achieved an adequate tidal volume, the other thing I can do is increase the respiratory rate. It is possible that the respiratory rate we set on a ventilator is not high enough, especially in a patient who is sedated or paralyzed. They might not be able to overcome the ventilator or overdrive the ventilator to breathe. So in this case, I will increase the respiratory rate to higher respiratory rate than what I initially set up.
Okay, so let's talk about the converse scenario where the patient's pH is adequate but they are hypoxic with a PaO2 of 52 on a current FiO2 setting of 80% on the ventilator.
Now we have a patient with hypoxic respiratory failure, and first step is also trying to find the cause of this hypoxic respiratory failure and trying to address it. But also at the same time, we want to make sure that the patient is oxygenating well. If a patient is on high FiO2, of course, they have two options here. I can either increase the FiO2 or I can increase the PEEP or positive index respiratory pressure. Somebody on a FiO2 of 80%, that's pretty high, but I still have some window to go up, and this is a quick fix. I can go up on FiO2 to 100% while I'm trying to figure out the causes of this hypoxia. That's the quicker fix than trying to change the PEEP. The PEEP works in a way of distending the alveoli and providing a wider surface for oxygen to transport from the alveoli to the blood. If a patient is in hypoxic respiratory failure, it's wise to start with an adequate PEEP. Generally, we start between 5 to 8, but sometimes you find yourself, you might have to go up to a PEEP of 10 or even 12, 14. Just remember that when you change the PEEP, the change in oxygenation or in the PO2 or a SAT might not be immediate, and it's more of establishing a recruitment and increasing this exchange surface in the lung. The quicker fix would be to increase the FiO2 to fix the oxygenation while you're trying to figure out other causes and other possible interventions.
All right, great. So thanks for explaining those concepts. What would be your take-home points to residents who are managing these patients in the ICU, particularly with regards to mechanical ventilation?
My first take-home message would be, one, remember the reason why you intubated the patient and why you put him on a ventilator and try to fix it. You cannot manage a ventilator. You cannot get rid of the ventilator until you fix the reason the patient got on the ventilator in the first place. Number two, trust the respiratory therapist, work with them. Number three, remember the importance of minute ventilation and tidal volume. You want to match the minute ventilation that the patient is asking for. You want to also keep the tidal volume in a safe range, 6 to 8 mLs a kilogram of ideal body weight, not the actual weight, the ideal body weight, which is dependent on the patient's gender and height. Remember the relationship between the pressure and volume. No matter what you choose, whether it's a pressure control mode or a volume control mode, you need to be watching the other end of the equation, which is if you use pressure, you want to watch for the volume. If you use volume, you want to watch for the peak pressure and the plateau pressure. Follow your ABGs, know where you are from the beginning, so any changes you make on the ventilator will make sense to you. You don't have to continue to check ABGs once you have a good grasp of where the patient sits from a ventilatory and oxygenation status and how they interact with the ventilator.
Great. Well, I appreciate you going over these concepts today. Hopefully this helps residents get a little bit better idea of how to get up and running safely after they intubate somebody or receive a patient from the OR who's on mechanical ventilation.
Thank you very much. Thanks for having me.
Thanks again to Dr. Tareq Kheirbek for joining us today on this discussion of mechanical ventilation. Please stay tuned for these and other Quick Shot podcast episodes in the coming weeks, where topics covered will include fluid resuscitation and sedation management in critically ill patients. I would love to hear your comments on these and other podcasts that we have put together. If you have ideas for other discussions, please email me. The link to my address is in the comments section below. Thanks for being here, and I'm looking forward to having you back with us in the next episode.